موجودة في الكتب. And I refer you to this textbook. It's a good textbook, the textbook of echocardiography by Catherine Otto. هتلاقي ان في اخر صفحه في اخره في صفحه 542 في different dimensions of different cardiac chambers and different dimensions valves والrings وكل حاجه whatever you want to look for is available in this text and in other texts as well, but they're one of the most recent prestigious texts on echocardiography. So we start with the final left to right shunt tonight, patent ductus arteriosus. This is one vascular structure that sometimes needs to be closed, sometimes needs to be open. So in preterm, it needs to be closed to prevent the recurrence of hyaline membrane disease progression into pulmonary dysplasia and pulmonary hypertension and cor pulmonale. And the way we close it at this stage of life is by intravenous infusion of indomethacin or ibuprofen, and recently by acetaminophen. Ibuprofen and indomethacin are nephrotoxic. Acetaminophen is not nephrotoxic, although it carries a little hepatotoxicity, but it is acting against the special radical in the prostaglandin synthase pathway. So it allows closure of the ductus and prevents overflooding and rigidity of the lungs in the preterm infants. You need also to open it sometimes in the neonate, in patients who are ductus dependent. For example, patients with pulmonary atresia, patients with interrupted aortic arch, or patients with infantile coarctation. But in adult life, the indication is clear. Not every ductus should be closed as it's generally appreciated by many of you, but if you hear it, if it's audible and producing the troubles, you close it. If it's inaudible or silent, or is not producing the troubles, although audible, you leave it. So if it's silent and tiny and non-audible, then you leave it. If it's small and audible, you also leave it. But if it's associated with enlargement of left side of the heart, left atrium, left ventricle, and pulmonary artery, and the aorta, then you close it. If you leave it, then they are very prone to develop Eisenmenger, and Eisenmenger in patent ductus arteriosus is associated with a huge elevation of the pulmonary artery pressure, simply because the pulmonary circulation is being exposed to systolic and diastolic pressure in the aorta. In the ventricular septal defect, it's subjected also to the systolic pressure, but in patent ductus subjected to double pressure, double high pressure, so it produces a huge elevation of the pulmonary artery pressure. You apply the 2/3 rule that we talked about last time with its modification, and if you get an Eisenmenger reaction based on the 2/3 rule, it's a contraindication to close the ductus. Under these circumstances, you find the differential cyanosis with blue toes and cyanotic legs, in contrast to the pink fingers and no clubbing of fingers in the upper arm. Now we know that you can get a reverse situation in which there is clubbing and blueness or cyanosis of the upper limbs and no cyanosis or clubbing in the lower limbs, and that occurs in conditions of transposition of the great arteries with patent ductus arteriosus. But the mistake here, you have to be cautious that the ductus in these conditions is shunting left to right, not right to left. So if it is normally rated great vessels, then it shunts right to left because of Eisenmenger. You get this kind of differential cyanosis that you can find in this picture. You get the reverse if you have the transposition of the great arteries and a left to right shunt. If you spend some time drawing them and imagining the pressure, you will reach to this conclusion. Now it's closed usually by coils if it's less than 3 millimeters. Previously, this figure was 8 millimeters. Now it changed it into 3 millimeters. As a matter of fact, most of the ducti are now closed by ductus occluder rather than coils. So the ductus occluders come in small sizes and can be as big as 30-something, and it can close the ductus. In old age, you get calcification of the ductus and surgery becomes a big problem. Now, if surgery can also be used in very big ducti or ducti that could not be successfully closed by a ductal occluder, and this is through thoracoscopic surgery, through 3 or 4 portals of entry in the fourth intercostal space. So the clinical important data about the ductus, usually it's an isolated lesion. It needs to be closed if it's audible and producing left-sided enlargement. As a Menger, you get pink hands and blue clubbed toes. Reverse of this situation occurs in Eisenmenger, complicating transposition of the great vessels, and occlusion usually carried out percutaneously. Now we move then to anomalous coronary arteries. It's a common condition, although it occurs in 1% of coronary arteriogram, but still very minor abnormalities occur much more frequently, like, for example, the origin of the conus branch by a separate orifice from the right coronary artery, from the right sinus of Valsalva, or 2 separate orifices for LAD and circumflex from the left sinus of Valsalva. But actually, only few of them are of clinical importance, and they are found incidentally during coronary arteriography. Half of this 1% is due to the circuit coming from the right coronary artery. Under these circumstances, it's of no concern. 100% of the time, it's a benign condition. If you get circ from the right coronary artery, it always passes behind the aorta, and it doesn't produce any problems. The problem arises when the right coronary artery arises from the left sinus, the LAD arises from the right sinus, or more importantly, when the left main arises from the right sinus and passes between the 2 great arteries. The LAD crosses the right ventricular outflow tract in about 5% of patients with Fallot's tetralogy. Previously, Fallot's correction was postponed beyond the 2nd year. Usually, we carry it out in the 3rd or 4th months of life, but it gets postponed beyond the 2nd year if you have the LAD crossing the right ventricular outflow tract. Now, this is no longer the case because you can always tackle the subpulmonary stenosis via the right atrium or via the pulmonary artery. So having the LAD crossing the right ventricular outflow tract in 5% of Fallot's tetralogy is no contraindication to early radical repair. So the most important thing is having the left main passing between the aorta and the pulmonary artery. And as you see here in this diagram on the right, you have a left main passing between the aorta and the pulmonary artery, and on the left, you have the LAD crossing the outflow tract of the right ventricle, as occurs in 5% or 3 to 7% of patients with Fallot's tetralogy. Now, one important point that I want to draw your attention to, if you have during coronary angiography in any view, the left main that long, think that it is passing between the 2 great arteries, particularly if septal perforating are coming from the left main. Usually the left main is 3 to 5 centimeters, but if it's longer than that, then try to find out why is the reason for that. Most likely it's because of the unusual course between the aorta and the pulmonary artery. Now, the reason, of course, is not compression. The reason of ischemia under these circumstances is obviously not the compression of the coronary artery by the aorta, because the pressure in the coronary artery is equivalent to that of the aorta. But the reason is usually a slit-like opening from the right sinus of Valsalva, and sometimes the vessel passes intramurally into the vessel wall, and sometimes it digs into the septum or under a bridge. And whenever the patient exercises, the pressure rises in both the pulmonary artery anteriorly and the aorta posteriorly and compress the vessel. So actually, there are 3 or 4 reasons for why the coronary artery gets compressed and produces ischemia. Now, if you have the coronary artery passing between the 2 arteries, then the surgery is one of 2 things. Either you detach it from the wrong sinus and implant it into the correct sinus and wrap it around the posterior vessel, or if it's passing intramurally, you just make an unroofing of the vessel. So that solves the situation. You have another orifice for the vessel, unroofed, and so it opens directly into the lumen of the aorta without having a slit-like opening or compression in the wall of the vessel. So what are the guidelines about anomalous coronaries? Class 1 indication, if you have anomalous left main coronary artery passing between the aorta and the pulmonary artery, irrespective of whether there is ischemia or not. The new European guideline is emphasizing the occurrence of ischemia, doesn't pay attention or doesn't pay too much attention to the course of the vessel. So whether it's passing between the two large arteries, so long as you have a large vessel producing ischemia by imaging, then it needs some form of intervention. The American guidelines indicates whether the left main is passing between the aorta and the pulmonary artery, you don't need a provocative test for ischemia, or if you have a documented ischemia and either coronary is passing between the great arteries. If you have some anatomical abnormalities in the coronary arteries, it's a 2A indication for intervention. So if you have vascular hypoplasia or coronary compression or obstruction of one of the coronary arteries, whether there is ischemia or not, it's a 2A indication for closing it. And a 2B indication is if you have an LED passing between the aorta and the pulmonary artery. So the indication is actually either you document ischemia or you document a large vessel passing between the two large arteries. Now, moving from this to the coronary fistula usually opens into a low pressure chamber, right atrium, right ventricle, or pulmonary artery. The guidelines is not clear. If you have a large fistula, you close it. If you have a moderate sized or a small fistula and producing troubles, producing ischemia or producing left ventricular dysfunction or producing arrhythmia, then you close it. Otherwise, you leave it. So the indications for closure of the coronary fistula, class 1 indication is a large fistula. The guideline writers didn't indicate exactly what's meant by a large fistula, but if it's large, you close it, irrespective whether there is an evidence of malfunction, ischemia, arrhythmia, or the systolic or diastolic malfunction. But if it is a small or moderate, then you look for evidence of ischemia, arrhythmia, or systolic or diastolic dysfunction, or an evidence of endarteritis. So these are the indications of closure of coronary fistula. Now going into several obstructive lesions, we start with coarctation of the aorta. Now, it's an important thing. The important thing first is to differentiate between pseudo-coarctation and coarctation. Coarctation, there is a gradient across this constriction, which is located in the aortic isthmus between the left subclavian and the ligamentum arteriosum. And in pseudo-coarctation, the coarctation segment is just a kink in the aorta here. Previously, we thought that pseudo-coarctation is a benign condition of no concern. Now, this idea has changed recently. Sometimes, if you leave a pseudo-coarctation without doing anything, it results in true coarctation with a development of a gradient. And sometimes the proximal or the distal segment undergoes aneurysmal dilatation and compresses the surrounding structures, particularly the tracheobronchial tree. So under these circumstances, it leads to, it requires surgical intervention. Of course, radiologically, everyone recognizes the figure of 3 pattern, which corresponds to the pre-stenotic dilatation, post-stenotic dilatation, and the aortic constriction, and also the recognizing the rib notching, which is present on either side or on both sides between the 2nd and the 9th rib, not above, not below, because above and below is supplied by intercostals from proximal segments, not across the coarctation. Now, the gradient which is required to diagnose significant coarctation is really low. It's just 20 millimeters of mercury. Whether you get this a resting gradient or an exercise gradient, this is an indication for surgical or interventional treatment. If you have collaterals, you know that it's tight. So even if the gradient is 10 millimeters of mercury or even less with extensive collaterals, or if you have 10 millimeters with left ventricular dysfunction or with aortic valve disease in association, this is an indication for surgery. So the presence of collaterals by itself connotes that we are dealing with a significant coarctation. If you get a gradient above 10 and particularly above 20, you need imaging to see the status of the coarctation, whether it's a tubular segment, long segment, short segment, because that has a bearing on the line of treatment. So the important facts about coarctation: never forget the presence of bicuspid aortic valve, because that needs post-op procedure follow-up for life. It occurs in more than 3/4 of patients, 85% of patients. And also look for other components of Turner syndrome, because gonadal dysgenesis requires a specific treatment. There are multiple surgical approaches for the infant. In the neonates and in infants and in small children, the treatment is surgical. You cannot put a stent because you cannot dilate the stent to adult dimensions in these groups of ages. If you have a child with recoarctation, the treatment is balloon dilatation without stenting. Again, for the same reason, you cannot get a stent and dilate it to adult proportion. If you get coarctation in adolescent or in adult life, then you can use either stenting or you can use surgical treatment, depending whether you are dealing with a discrete coarctation or a longitudinal coarctation. Now, priority according to the European guidelines is always given when feasible to stent dilatation and stenting. Usually stenting, we choose a stent with a diameter which is 2 to 4 times the coarctation segment, provided that the diameter does not exceed 2 millimeters below the aorta at the level of the diaphragm or proximal to the coarctation. In adults, you have to watch for the blood pressure. It usually doesn't drop after correction of the coarctation and needs treatment. And sometimes you can get a rebound marked elevation of the blood pressure because of improvement of the cardiac output, increase of a vasoconstricted circulation as a result of sympathetic stimulation and prior renal ischemia. You always need imaging in addition to hemodynamic studies. So the intervention is indicated when the peak-to-peak gradient at rest or on exercise more than 20 millimeters of mercury. And even if it is less than 20 millimeters of mercury with extensive collaterals, left ventricular dysfunction, aortic regurgitation as a result of bicuspid aortic valve, these are all indications for intervention. It's important to follow up these patients for the occurrence of post-procedure or post-surgical recoarctation, aneurysm at the site of surgery, ascending aortic aneurysm, coronary artery aneurysm, and perianeurysms in the brain. Now, as you see from this picture, on the left is a native coarctation, on the right, stenting of the coarctation. We don't oppose the stent as we do in coronary artery intervention. You just widen the coarctation area, abolish the gradient or decrease it markedly, and keep the stent flared upstairs here and flared downstairs so it doesn't fall. And there is no need that you oppose it completely and open the aorta. Otherwise, you are prone to make a dissection, weakening, and aneurysm formation in this area. Now, the second obstructive lesion that I wanted to allude to is the subaortic stenosis. It's a membrane located here, sometimes very difficult to see, but if you find the turbulence below the aortic valve, you should be on the lookout for this condition. Sometimes it appears in MRI and you miss it in echo, and it appears as a discrete segment below the aortic valve. And sometimes, as you know, that the distance can be very small here to the extent that you get confused. But always the barotrauma results in associated aortic regurgitation. Now, it's a wide spectrum. So the membrane has a wide spectrum of anatomic presentation. It varies from just a membrane to a complete tunnel. Occasionally, there is accessory mitral chordae below the membrane and attached to the membrane itself. It's acquired over time because it's not usually seen in the neonates. And if you remove it before the age of 10 years, there is a high incidence of recurrence. That's why if you don't have a pressing need for removing the membrane, then you better postpone the procedure until after 10 years of age. Now, Sean syndrome is multiple obstructive lesions. It consists of coarctation, bicuspid aortic valve, subaortic stenosis, and the parachute mitral valve, which is a single papillary muscle with the chorda tendini attached to both leaflets, or a mitral arcade in which the papillary muscles are immediately below the mitral leaflets without an intervening chorda tendini, or a supramitral membrane, or a mitral ring, or a mitral web. So whenever you get subaortic stenosis, you have to exclude all these associations which constitute Jones syndrome. It's a progressive lesion, and it might recur after surgical resection. If you try to open it with a balloon, usually you will fail. Percutaneous balloon dilatation is poorly effective, and usually it needs surgery or after the age of 10 if you can wait. The indication is a peak gradient of 50 millimeter of mercury or a mean gradient of 30. As you see, a mean gradient here is less than an aortic stenosis, which is 40. And the reason for that is to avoid the occurrence of aortic regurgitation if you leave the subaortic membrane with the consequent barotrauma to the aortic valve. You might even do that if there is less gradient, but there is an aortic regurg that is becoming severe, or a left ventricular dilatation, or a poor ejection fraction. And a 2B indication if the gradient is less than 30 millimeters of mercury, but there is significant left ventricular hypertrophy, or the patient is planning for pregnancy or strenuous sports. Now, the next obstructive lesion is pulmonary stenosis. If you find the dome-shaped valve like this with a post-stenotic dilatation, that's a valvular pulmonary stenosis. Sometimes the infundibulum is narrowed, but this is usually a dynamic process which responds to post-procedure or rarely post-surgical beta blocker. Rarely surgery is indicated to remove the subpulmonary obstruction. This is different from pulmonary dysplasia. In pulmonary dysplasia, you get a thick transverse membrane and usually no post-stenotic dilatation. So the presence of post-stenotic dilatation, which involves the main pulmonary artery and usually the left pulmonary artery, because the jet is usually directed into the left lung more than in the right lung. So under these circumstances, the treatment of choice is obviously balloon dilatation. The diameter of the balloon should be 120 to 140% of the diameter of the pulmonary ring. So it's 25% more than the diameter of the pulmonary ring. As we said in coarctation, it should be 2 to 4 times the coarctation segment, not more than 2 millimeters below the proximal aorta or aorta at the level of the diaphragm. And in aortic stenosis, it should be 1 millimeter less than the diameter of the aortic ring. So for the 3 obstructive lesions, the balloon dimensions is different and should be remembered as such. Now, the important data about pulmonary stenosis, it is the valvular pulmonary stenosis. It's the most common form of right ventricular outflow tract obstruction. There is fusion of the cusps, and there is preferential flow to the left lung, as I indicated a while ago. The severity varies from mild to atresia. There is doming of the valve. Dysplasia is common in Noonan syndrome and can be managed by surgery. Occasionally, dysplasia responds to balloon, but that's rare. And there are rare reports in which dysplasia can be opened by the balloon, and after doing that, the valve matures and the dysplasia disappears. But this is just sporadic case reports and should not be generalized. Patients with mild to moderate severity, they usually tolerate the procedure of the disease for a long time, and so we can postpone the balloon dilatation. Right ventricular hypertrophy can be significant, and if cyanosis is present, think of an opening for an valve. Now, a common examination question that comes in the multiple choice questions is that the ejection click, which occurs with valvular pulmonary stenosis, is the only right-sided auscultatory event which decreases with inspiration. With inspiration, you open the valve partly, so the movement of the valve from the partly open position to the completely open position is not sufficient to create an ejection click. So with inspiration, the click decreases. Any other right-sided phenomenon increases with inspiration except the pulmonary click, and that's a common question. Now, in asymptomatic individuals, you just need a mean gradient like with aortic stenosis more than 40 millimeters of mercury. If you have a peak gradient more than 64, that's 4 meters velocity, then this is very severe and is an indication for intervention, of course. Or if the mean gradient is just above 30, but the patient is having symptoms. Usually, surgery is rarely indicated, but sometimes it's indicated if there is significant pulmonary leakage, or if the subvalvular or supravalvular stenosis is there, particularly if the subvalvular stenosis remains for several weeks and months and are not responsive to treatment with beta blocker. Suicidal right ventricle is a rare phenomenon because of the intense subvalvular stenosis that does not respond to volume loading or beta blockade. Balloon valvuloplasty is rarely effective, but it should be tried in these plastic valves because, as I just mentioned, that sometimes it succeeds in the dysplastic valve. Under these circumstances, time alone is sufficient to let maturation of the valve. Now I move to Epstein's anomaly. Epstein's anomaly is displacement of the septal and the posterior leaflet of the tricuspid valve into the right ventricle. Now the textbook mentioned that never the anterior leaflet. There is nothing called never. Sometimes the anterior leaflet is involved as well, but usually the anterior leaflet is not misplaced, but it's large, fenestrated, muscular, and it's not displaced like the septal and the posterior leaflet. Sometimes the displacement is so marked that to the extent that the right ventricle is very diminutive. Under these circumstances, the condition is treated as single ventricle glands bidirectional gland followed by full Fontan operation. Now, as you see here, the tricuspid valve is usually the lower valve. So the criterion is if you compare the septal leaflet of the tricuspid valve with the anteromedial leaflet of the mitral valve, you get a separation by 0.8 centimeter per square meter body surface area. Now, the previous guidelines was giving two figures, 20 millimeters absolute figure and 0.8 millimeters millimeter per square meter body surface area. The two cannot correspond to each other unless the body surface area is 2.5 meters, which is huge for these individuals. So the new guidelines erased the 20 millimeter and kept it at 0.8 as the distance which is accepted, 0.8 or more. Normally, as you know, the septal leaflet of the tricuspid valve is normally more apically displaced than the anteromedial leaflet of the mitral valve. But if this degree of displacement is exaggerated to the extent that I described, then you diagnose Epstein's anomaly. Now, the ECG is a little trick because usually about 15% of these patients, they have an associated type BWBW. So the delta wave is negative and the right precordial leads. But the important trick here is that these patients also very frequently have a right bundle branch block. So there is pseudo-compensation. The right bundle is being compensated by the pre-excitation as a result of the right-sided accessory pathway. So you get a QRS complex, short PR interval, but a normal shape and the narrow QRS complex. Neither right bundle nor pre-excitation phenomena with delta wave. And the reason for that is the compensation or pseudo-compensation caused by the combination of right bundle branch block on the right side, of course, and the right-sided accessory pathway, which is responsive. If you don't get a right bundle branch block, then you get a YQRS complex. If you don't get type BWBW and right bundle branch block alone, you get a right bundle branch block. So the QRS can be upright if there is right bundle branch block, can be inverted if there is type BWBW, and can be almost normal if there is a combination of both. Now, the clinical data about Epstein, it is a displacement of the septal and posterior, not the anterior leaflet. The displacement is 8 millimeters per square meter body surface area. There is a large anterior leaflet. It produces a sail sound like that, like the wind filling the Mercury. There is arterialization of the right ventricle, which is thin and dilated. A common association is an atrial septal defect or patent foramen ovale. Every patient with Epstein should be exercised. If he shunts right to left and gets cyanotic, it's an indication for surgical intervention. There was a previous outmoded theory that lithium intake for acute manic psychosis and affecting the mother is responsible for Epstein. Of course, that's proved to be an erroneous conception. It may be caused by, it may cause an AV valve regurgitation in congenitally corrected transposition. We will explain corrected transposition now. The left-sided valve is the tricuspid valve. You can get an Epstein-like malformation. It's like because there is no large anterior leaflet and there is no atrialization of the right ventricle. So it's similar to Epstein. It occurs only in 5% of these individuals. Right-sided accessory pathway is present in 15%. Patients can get the tricuspid regurg, but because of the large size of the right atrium, you don't get systolic expansion in the neck veins, and you don't get manifestations of right-sided heart failure, except when the right ventricle is undersized. Exercise cyanosis is a common association with preterm foramen ovale and the atrial septal defect, and at present, it's an indication for device closure. Surgical treatment is actually a big problem. But if the patient is having symptoms, then he should have surgery. If the patient is having resistant arrhythmia or a right ventricular dysfunction, is an indication for surgery. Now, the surgery is usually creating a monocuspid valve for the tricuspid position, or fashioning the valve in a special way called the cone reconstruction. It's cone-like structure or fashioning of the tricuspid valve. If the right ventricle is very small, then you do a bilateral Glenn operation. Under these circumstances, you have what is called 1.5 ventricular repair. 1.5, one is the left ventricle is acting as a systemic ventricle, and the half, because the inferior vena cava blood is shunted like normal to the tricuspid valve, and the other half of the vena cava return is going to the pulmonary artery. So one is left ventricle, and the half is the inferior vena cava blood going to the right ventricle. So if you get manifestations related to cyanosis by crossing an atrial septal defect or preterm foramen ovale, or a significant tricuspid stenosis or right ventricular dysfunction, then you think of Epstein's anomaly, or as it's pronounced, the Epstein anomaly, to the tetralogy of Fallot. The tetralogy of Fallot is actually immunology. And the reason for that is the corner septum, or the outflow tract septum here, is moved anteriorly and superiorly. And in this way, it creates a malaligned VSD, which is actually a perimembranous VSD, large enough to equalize both ventricular pressures. And it creates also this movement of the infundibular septum, creates the pulmonary stenosis. The pulmonary valve might be bicuspid. It might or might not be stenotic by itself. And there is overriding of the aorta. Less than 50% of the aorta overrides the septum. If it's more than 50%, then it's double outlet right ventricle. Same syndrome, but with different classifications, as we will probably say in the discussion. And as I said, about 5% of these patients have the LAD moving across the right ventricular outflow tract, no longer a problem, because we can approach the right ventricular tract pathology through the right atrium and through the pulmonary artery, and not necessarily by the right ventricular. Now, the right ventricular outflow tract and the pulmonary artery is not mature enough to support the radical treatment or radical repair of tetralogy. Then under these circumstances, we initiate the treatment by palliative procedures. And the only palliative procedure that remains now is the modified valve-toxic shunt. The modified valve-toxic shunt is side-to-side anastomosis between the subclavian right or left and the corresponding pulmonary artery. It's a vortex tube. And this is in contrast to the classic valve-toxic shunt, which is an end-of-side anastomosis between the subclavian on the opposite side of the aortic arch and the corresponding pulmonary artery. The water stones of shunt and the POTS shunt are uncontrollable. They can produce pulmonary edema or pulmonary hypertension, so they are no longer used, but you might see some previously done procedures. So the waterstone shunt is a shunt between the right pulmonary artery and the ascending aorta, and the POTS shunt is an anastomosis between the left pulmonary artery and the descending aorta. Now, because fellowship tetralogy repair usually entails widening the right ventricular outflow tract, sometimes it's so narrow that you need to patch the right ventricular outflow tract. If you patch the right ventricular outflow tract, you are prone to produce two major problems. Number one, ventricular arrhythmia, which is a re-entry arrhythmia or a surface movement arrhythmia around the patch, or around the patch which closes the ventricular septal defect. And the other thing, patching the outflow tract, particularly when it encroaches on the pulmonary ring, can produce severe pulmonary regurgitation. Sometimes the pulmonary valve disappears almost together. Some centers, they insert a monoleaflet in the outflow tract of the right ventricle during this procedure to avoid the post-operative occurrence of pulmonary regurgitation. But pulmonary regurgitation is the most important problem in patients of fellowship tetralogy that have undergone radical repair. So the clinical about fellowship tetralogy is that it's the most common cyanotic congenital heart disease at birth, accounting for 10% of cyanotic congenital heart disease. In adults, most of people with fellowship tetralogy having repair. It's not a simple surgery, it's a complex surgery. And you have to observe the patient in the post-operative state for the important complications. And the most important complication is the occurrence of pulmonary regurgitation. And this pulmonary regurgitation is a tricky pulmonary regurgitation. The murmur is very soft, and I will tell you why next slide. But at the same time, the echo might miss completely the condition because it's a free pulmonary regurgitation and there is no disturbance or disturbance that can be overlooked very easily. You need to have a cardiac
محمد صوت حضرتك بيقطع. تمام؟ صوت حضرتك بيقطع يا فندم.
Explained otherwise, the simple regurgitation is severe and producing right ventricular and unsteady. ثانية يا محمد.
صوت حضرتك كان بيقطع في الدقيقتين اللي فاتوا.
كده كويس، انا غيرت دلوقتي الانترنت.
كده احسن كده.
طيب اذا قطع تاني قول لي عشان انا نغير الانترنت تاني. So ventricular arrhythmia is usually related to the outflow patch with the occurrence of pulmonary regurgitation. Sometimes correcting the pulmonary regurgitation by itself is sufficient to abolish the right ventricular dilatation and abolish the occurrence of arrhythmia. If arrhythmia persists after correction of the mechanical problem, that's pulmonary regurgitation, then an ICD is indicated. Always in congenital heart disease, if you have a ventricular arrhythmia, think of a mechanical problem, try to correct the mechanical problem, and then watch the patient. If the arrhythmia disappeared, that's it. If the arrhythmia didn't disappear, it's an indication for ICD. Other issues that needs to be looked for in the post-operative fellowship tetralogy is dilated aorta. Remember, the aorta is not, although it's not a component of the tetralogy itself, but the aorta is abnormal consistently in fellowship tetralogy, whether that's cystic median necrosis or otherwise, is not settled, and you can get an aortic regurgitation in the post-operative state. You can get also left ventricular dysfunction for a variety of reasons, including the occurrence of aortic regurgitation, a residual ventricular septal defect that has not been closed, interruption of the LED that's passing across the right ventricular outflow tract, or malperfusion during the bypass procedure. So as a result of any of these things or all of them in combination, you might get left ventricular dysfunction. Sometimes the left ventricular dysfunction disappears by correcting the pulmonary regurg and shrinking the right ventricular size to its normal dimensions. Ventricular dysfunction is obviously will be associated with atrial arrhythmia. And as I said, the most important thing to remember from this slide is that ventricular arrhythmia might improve and resolve after correcting the pulmonary regurgitation, which is a complication of the patch in the outflow tract. Now, this will show you how the murmur of pulmonary regurgitation in fellow cytology can be easily overlooked, because you have pulmonary stenosis and low right ventricular pressure in these conditions. After correction of the pulmonary stenosis, you get a small gradient, so the murmur is very soft. This is in contrast to Graham-Steele murmur, which complicates, which is pulmonary regurgitation that complicates pulmonary hypertension, where the murmur, here is the murmur is almost inaudible. And the situation is complicated that no turbulence is present usually during echocardiography, because the gradient is small and is restricted only during the rapid filling period. And the only thing that directs your attention is the extensive right ventricular dilatation, MRI, and cardiac catheter and angio-injection in the pulmonary artery. So this is an important thing. The right ventricular dilatation, which can occur because of pulmonary regurgitation, can result in widening of the right bundle branch block, wide QRS complex. If the QRS complex exceeds 180 milliseconds, that's a harbinger of ventricular tachycardia and ventricular fibrillation. So you have to be on the lookout for a wide QRS complex, for right ventricular dilatation, for pulmonary regurgitation, for 180 millisecond of QRS complex, and the possible occurrence of ventricular tachycardia, ventricular fibrillation, and sudden death. So the important points about tetralogy repair is that whenever you have severe pulmonary regurgitation with symptoms, that's a class 1 indication for repair of the pulmonary regurgitation. It can be done either instrumentally by melody valve, or it can be done surgically. If you have severe pulmonary regurgitation with right ventricular dilatation or right ventricular enlargement, and here the guidelines indicates a cutoff point, right ventricular end-diastolic volume index of 140 millimeter or more, then this is an indication. Or if you have symptomatic atrial or ventricular arrhythmia, or surgery is also indicated for other reasons, like a residual outflow tract gradient above 50, or right ventricular systolic pressure that's high, 0.7 or more of the left ventricular systolic pressure, or a residual gradient across or progressive right ventricular dysfunction, or a residual shunt with a significant left to right shunt, aortic regurg with symptoms or left ventricular dysfunction, or a combination of these events. So these are the important indications for the surgery after TET repair. They are important and subject to many questions. Despite all of these, whenever you have a good repair, you get an excellent result. This is a picture of Sean White, which is an Olympic golden medal winner for 2 times in skiing. He had a fellow cytology and successful repair, and he was a very eminent champion. Now we have to talk about the transposition complexes. We'll start with congenitally corrected transposition, also known as physiologically transposition. And I wanted to introduce the subject of transposition by some pearls. The first pearl is not, there is no slide here, so concentrate with that for the coming 2 minutes. The first thing is the loop theory of Van Braght. The loop theory says that we have an L loop or a D loop for ventricular arrangement. If the primitive cardiac tube bends to the right, then the anatomical right ventricle will be to the right of the anatomical left ventricle. If it bends to the left, then the anatomical right ventricle will be to the left of the anatomical right ventricle. So if it bends to the right, the anatomical right ventricle will be to the right. If it bends to the left, then the anatomical right ventricle will be to the left. This is the D loop and the L loop. Now we come to the definition of transposition. Transposition means that the pulmonary artery is posterior and the aorta is anterior. If the aorta is anterior and to the left, this is L transposition. If it's anterior and to the right, this is detransposition. Now we link together these two phenomena. So if you have D loop, it goes with detransposition. If you have L loop, it goes with L transposition. So this is the first fact. The second fact, the AV valve goes with the corresponding ventricle because it develops from the myocardium of the corresponding ventricle. So always the tricuspid valve opens into the right ventricle, and always the mitral valve opens into the left ventricle. And you know that the tricuspid valve is apically moving, so it's lower than the mitral valve. There are differences between the ventricles, but the important difference is that which AV valve is connected to which ventricle. If it's tricuspid valve, then it's the right ventricle. If it's the mitral valve, it's the left ventricle. The third rule, in transposition, whether detransposition or L transposition, always the right ventricle is in the systemic circulation, and that's a big problem. Now, knowing that, we start with the congenitally corrected transposition. The congenitally corrected transposition is an L transposition. So here, you have one thing abnormal. The ventricles are inverted. Everything otherwise is normal. In detransposition, everything is normal except the vessels are inverted. Very simple. In L transposition or congenitally corrected transposition or physiologically corrected transposition, these are synonyms. The ventricles are inverted. So the left ventricle is to the right ventricle is to the left. Everything otherwise is normal. In detransposition, it's the vessels which are inverted. So the aorta rises from the right side, and the pulmonary arises from the left side, and everything otherwise is normal. So let's concentrate on congenitally corrected transposition. The left ventricle is to the right ventricle is to the left. So the right atrium opens into a mitral valve, because this is the left ventricle, into the left ventricle, and this left ventricle opens into the pulmonary artery. The blood comes through the pulmonary veins to the left atrium, which opens into a tricuspid valve. 5% can be Epstein-like, and this opens into the right ventricle, and then this moves into the aorta. So as you see, it's physiologically corrected. The venous blood will go to the lung, the arterial blood will go into the aorta, and therefore these patients, if they don't have any other abnormalities, they can live to the 8th or the 9th decade. Now, as you look into the echocardiogram, you will find that the right ventricle is on the left side here. The right ventricle is on the right side, is on the right side here. It's a systemic ventricle, and the pulmonary ventricle is the left ventricle and is located on the right side. Now, if you look into the lateral view an MRI, this is the left atrium, opens into a tricuspid valve that might be epistenoid, and this opens into the right ventricle, which opens into the aorta anterior. So the left atrial blood, which is oxygenated, goes into the aorta, but the problem is that the right ventricle, as in any transposition, is located in the systemic circulation, so it fails and it produces a horrible tricuspid regurgitation. Now, these patients with L transposition, they have inverted conduction systems, so they are prone to the development of conduction defects. And as I mentioned before, they have a risk of developing complete heart block, 2% per year. So if they live 20 years, there is a possibility that half of them will get a pacemaker. So 2% per year is a common question. The important data about L transposition is that very commonly they are associated with the combination of pathology, PS and VSD. Aortic regurgitation may be seen in certain conditions. They may be discovered late in life, as I said, 8th decade or even the 9th decade, if there is no associated significant abnormalities. The systemic ventricle is the right ventricle, like in any transposition, corrected or otherwise. The tricuspid valve resembles the Epstein-like valve, and this occurs in a large number of patients. They are prone to regurgitation, and they need to be repaired or replaced. Usually they have to be replaced because repairing these conditions is extremely difficult. The pulmonary ventricle is the anatomical left ventricle, and 50% of them, as I mentioned, they have pulmonary stenosis, so they have outflow tract obstruction. You might get heart block in about 2% per year in these conditions. And if you encounter a child with this condition, then you need a double switch operation, an atrial switch operation, as well as an arterial switch operation. And I will explain that shortly after that. But you might think about this. This is a horrible operation, but it corrects the whole situation if you can do it. So this is called a dual switch operation. You change the venous blood coming to the atrium into the opposite direction, and change the arterial blood coming from the ventricles into the opposite direction, and I will explain this in the next few slides. In adults, it's very difficult to carry out such a complicated operation, so you need medical therapy for congestive heart failure, including CRT, pacing for complete heart block, ICD implantation if it's needed, and many patients, they end up with cardiac transplantation if they can survive and they are eligible for cardiac transplantation. Now, if you move to D-transposition, here the right ventricle is a D loop, so it's located to the right of the left ventricle. And what's inverted here is the vessels. Everything otherwise is normal. Remember, in L-transposition, the ventricles are flipped. In D-transposition, the vessels are flipped. And otherwise, everything is normal. So the right atrium opens into the tricuspid valve. Why the tricuspid valve? Because the right ventricle is on the right. But this is in the systemic circulation like any transposition, so it opens into the aorta. The arterial blood comes through the pulmonary veins, open into the mitral valve. Why the mitral valve? Because it opens into the left ventricle, but unfortunately the left ventricle will eject the blood into the aorta, into the pulmonary artery. So as a result of that, the two circulations are in parallel, not in series. So there must be a hole located in the atrial septum or in the ventricular septum for mixing to occur and survival to be achieved. So in infancy, we put a Rashkind, we do a Rashkind procedure or a Baker procedure if it's after the first few weeks. And as I said, you think of the situation as if just the great arteries are flipped and nothing else is happening. Now, if you look into the echo in the apical four-chamber view, the systemic ventricle, as usual in transposition, is the right ventricle. The pulmonary ventricle is in the left ventricle. You find the right ventricle trabeculated with a moderator band. But the most important thing is that the tricuspid valve is more apically located, and the tricuspid opens as a rule into the right ventricle. If you find in the short axis view, the aorta and the pulmonary artery are seen in the same view, this means that they are parallel. Only two situations in the whole congenital heart disease can produce this picture. One of them transposition, whether D or L, the other is double outlet of the right ventricle. So if you see this picture, it's either, you cannot see the pulmonary artery and the aorta normally in the same view because they are crisscrossing each other and they are not parallel. They are parallel in these two situations, transpositions as well as double outlet right ventricle. So how can you treat it? You have an old operation which is the atrial switch operation. ده كانك بتركب بنطلون هنا هو دي رجلين البنطلون في السوبيريور فينا كيفا والانفيريور فينا كيفا وده الويست بتاع البنطلون عند الليفل اوف ذا mitral valve. And so the blood comes from the superior vena cava to the inferior vena cava and the inferior vena cava through the baffle. The baffle can be artificial valve, baffle, synthetic baffle in mustard operation, or can be atrial tissue in Sinning operation. And then the blood will be directed towards the left ventricle, and from the left ventricle it will go to the pulmonary artery to be oxygenated, and then it goes back into the left atrium, and then the blood oxygenated from the left atrium will move around the baffle from the outside and goes through the tricuspid valve to the right ventricle, and from the right ventricle to the systemic circulation. So you are correcting physiologically the circulation, but the problem is that the right ventricle is remaining in the systemic circulation, so is prone to fail, produce arrhythmia, as well as severe tricuspid regurgitation. And therefore, it has been replaced by the Jatin operation, or the not atrial but arterial switch operation. And this is carried out in 4 stages. This is the aorta anteriorly and to the right because it's a D transposition. and you detach the coronary arteries, attach them to the posterior located pulmonary artery, and then you cut the aorta and the pulmonary artery and switch them. So the proximal aorta goes into the distal pulmonary artery, and the proximal pulmonary artery goes into the distal aorta. And then the fourth stage is to bring the pulmonary artery anteriorly. This is called the Lecomte maneuver, in order to decrease the tension on the stitches. So these are the 4 stages of the Jatien operation, Brazilian surgeon, and this arterial switch operation will result in having the right ventricle in the pulmonary circulation, and the left ventricle is in the systemic circulation. The left ventricle here will go into the systemic circulation, proximally the pulmonary artery, distal the aorta, so this is the systemic circulation, and the right ventricle will go into the old aorta and the pulmonary artery, so that's the pulmonary circulation. So it solves the problem. The big problem is you have to do this operation in the first few weeks of life. If you miss the first few weeks of life, you need something called the training of the left ventricle. Because if you miss the first few weeks of life, the pulmonary artery pressure will drop, the right ventricle, the left ventricle will atrophy, because it has to work against a low pressure. And if this remains for quite a long time, and then you switch the vessels, the left ventricle cannot support the systemic circulation. So what to do? Do a pulmonary banding, and this pulmonary banding lasts for several months. Previously, we thought we can do it in 2 weeks. Now this is obsolete. Short-term training is obsolete, and you can do this only in childhood and adolescence. In adults, you cannot do that, and the new European guidelines is putting arterial pulmonary artery banding and the training of the left ventricle as class 3 indications in adults. So if you catch the patient in early life, you do an arterial switch operation. It solves the problem to a very large extent. These people can live to the 20s, 30s, and 40s. Now, we have the double switch that I just alluded to in corrected transposition. The double switch in corrected transposition includes the atrial switch plus the arterial switch. So this is a very complicated operation, but if you catch the child with corrected transposition early in life and you have a capable surgical team, they can do it. Now, the clinical data about detransposition, the atria are connected to the corrected ventricle, because as I said, the problem here is not in the atrium of the ventricle, it's in switching of the vessels, flipping of the vessels. But ventricles are connected to the wrong arteries. You need VSD or ESD to survive. If not, if they are not present, then you have to do a Rashkin atrial septostomy or a Baker's atrial septostomy. And then left ventricular outflow tract obstruction occurs in 25% of patients and usually is associated with the VSD. The atrial switch operation, which uses the synthetic material, is mastered operation using the atrial tissue thinning operation. Baffles the superior vena cava and inferior vena cava to the mitral valve. Pulmonary blood flow around the valve goes to the tricuspid valve. The atrial switch procedure remains will keep the right ventricle in the systemic circulation, and that's a problem because the right ventricle will eventually fail. At the same time, working in the atrium, cutting the atrial septum, and putting all these sutures here will result in sick sinus syndrome. So this patient gets tachybrady syndrome. The baffle can be obstructed, particularly if you put a pacing wire, because these patients are prone to complete heart block. And if the pacing wire produces baffle obstruction, then the baffle pressure will rise and baffle leak will occur. The systemic AV valve, which corresponds to the right ventricle, which will fail, will result in AV regurgitation, tricuspid valve regurgitation. If the patient is having pulmonary stenosis and VSD, then the line of treatment is a steady operation, and I will explain it in the next slide. And the definitive treatment is actually the arterial switch operation or Jatien operation is now the preferred. If you catch the child in the first few weeks of life, that's the operation to be chosen. If not, then you can train the left ventricle long term, not short term. If you don't catch the patient during adulthood, then the patient will need usually repair of the associated defects, and he will be moving down the pathway of heart transplantation. Now this is the Rastelli operation. The Rastelli operation is done for patients with transposition, detransposition, in association with pulmonary stenosis and VSD. So the VSD is closed, provided that the left ventricle will have its blood moving into the aorta. Then you disconnect the pulmonary artery completely from the right ventricle and from the left ventricle, and then you insert a conduit, a valved conduit between the right ventricle and the pulmonary artery. So under these circumstances, you have the oxygenated blood coming from the left ventricle directed into the systemic circulation. So the right ventricle is no longer supporting the systemic circulation. At the same time, the right ventricle will be moving into the pulmonary circulation by a valved conduit connecting the right ventricle into the bifurcation of the pulmonary artery. Now, the big problem with the arterial switch operation or Gitane operation is that the implantation of the coronary buttons into the aorta. The sutures in this area can produce complete obstruction or severe narrowing of the left main coronary artery, and this can produce severe myocardial infarction or myocardial ischemia, left ventricular dysfunction, mitral regurgitation, sometimes tricuspid regurgitation. So one has to be on the lookout for ischemic manifestations under these circumstances. So in short, you have to focus on the broad concepts for congenital heart diseases, understand the anatomy of the most common lesions and the associated surgery, and be aware of the clinical features of each lesion, and be aware of the guideline recommendation for surgical intervention of the most common lesions. Now, generally, surgery is indicated in congenital heart conditions for the following. This summarizes everything. If you have a severe lesion plus one of the following, a severe lesion plus one of the following symptoms, obviously you need surgery, plus one indication, or severe ventricular dysfunction, or arrhythmia, or you have, as a result of that, you have a severe lesion. Like, for example, if you have pulmonary stenosis, the gradient is not 40, but is 50 or 60, particularly if the peak-to-peak gradient more than 64, or severe tricuspid regurgitation and corrected transposition. So these are severe lesions. So if you have severe lesion with one of these four things, that's indication for surgery. If you have moderate or severe lesion and you are going to do surgery for another structure like aortic aneurysm or bicuspid aortic valve, then it's also class 1 indication, sometimes class 2A indication. So generally, the indication for surgery in patients with congenital heart disease is severe lesion plus symptoms, ventricular dysfunction, including ventricular dilatation, arrhythmia, or very severe lesion, or a moderate or severe lesion and surgery for another structure. So I stop at this stage. This completes congenital heart disease, and I'm ready to get your questions. Okay. I hope ان الانترنت ما قطعتش.
لا الصوت كان يا دكتور محمد ما قطعش تاني.
ممتاز. أسئلة. مفيش أسئلة؟
لا ما فيش أسئلة.
طيب خلاص. تصبحوا على خير. شكرا جزيلا.
الدكتورة وفاء كانت معانا بس عندها مشكلة في الكونكشن فهي بتعتذر لحضرتك.
ما فيهاش حاجة. شكرا.
في سؤال جه لو حضرتك تسمح له. بيسأل عن البالون سايز in different lesions.
احنا اتكلمنا البالونز اللي بنستخدمها في الاوبستراكتيف ليجنز. الاوبستراكتيف ليجنز اللي عندنا اساسا هم ما ياتي pulmonary stenosis بنستخدم بالون سايز 120 to 130 of the pulmonary annulus او 25% more than the pulmonary annulus, diameter of the pulmonary annulus. In coarctation we use بنقيس الcoarctation segment الديامتر بتاعها وبنستخدم بالونه وستنت يكون when fully inflated 2 2 to 4 times the diameter of the coarctation signal provided ان الرقم اللي هيطلع عندي ده هو ما يعديش 1 ملم above البروكسيمال اورتا او الاورتا at the level of the diaphragm عشان ما كريتش تير والتير ده يحصل فيه سودو اناليزم او يحصل فيه اناليزم او يحصل ليكج او يحصل رابشر او يحصل دايسكشن. بالنسبه للاورتيك ستينوزس هنا البالونه لازم تبقى اقل من الاورتيك فالف diameter usually by 2 ملم. So we oversize in the pulmonary, we undersize in the aorta, and usually we get somewhere in between for coarctation.
تمام، شكرا دكتور محمد. وما جاش اسئله تاني.
شكرا يا جماعه.
شكرا لحضرتك.
المره الجايه باذن الله فالفولار ديزيز، وبعد ما نخلص الفالفولار ديزيز هنشوف بقى هل تحبوا ان نكمل فاضل لنا بعد كده 10 محاضرات ولا نتوقف شويه تذاكروا وبعدين نرجع. يعني you have to decide for yourselves. I'm ready in both directions.
تمام، اوكي.